Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
Today's presenter is Alexander Saw. Dr. Saw is a native of Fremont and was born at Washington Hospital. Dr. Saw completed his bachelor's degree at Haverford College in Pennsylvania. He completed his internship at Massachusetts General Hospital and his residency at Harvard Combined Orthopaedic Residency in Boston. Dr. Saw completed his fellowship in minimally invasive and revision hip and knee replacement at Rush University Medical Center in Chicago.
As you can see from the title of this talk, we're going to talk mostly about knee arthritis, knee pain, and knee replacement, but we're also going to talk about how things have dramatically changed over the years, and most recently this past year and a half, at least in our practice here. How many of you have knee replacement? Do many of you in the room already have a knee replacement? So a good number of you. Okay, and many of you probably know people who've had knee replacement before. It's very common. Nearly 1 million are done in the United States every year, so it's a common problem. Arthritis strikes a lot of us as we do more, age more, and want to stay active. So we'll talk about all of those things. As you heard, I was born here, raised in Fremont, born at this hospital. You heard about my educational background. I came back in 2008. My father, some of you may have known, he was a head and neck surgeon. So this is him here. He was a ear, nose, and throat doctor. He was on the hospital board and chief of staff. But it's great to come back and serve the community where I grew up. And it's great to work with many of the patients who were also patients of my father or work with colleagues of his. This is what I do. I do hip replacement, knee replacement, revision surgery, and also partial knee replacement, which we'll talk a little bit about this afternoon. It's sort of a slight change from total knee replacement for people who have arthritis in only one part of their knee. We have a large program here. We do a lot of joint replacements, probably more than anyone else in the Bay Area. And so with that, it gives us great opportunity to be involved on a local level with our Institute for Joint Restoration, but it also allows me the opportunity to give lectures at national meetings or be on faculty or on various committees of state and national levels. So we're very fortunate to have such a successful and large joint replacement program here in Fremont, and it's something that certainly my partner and I take very, very seriously. It's a great privilege for us. And this is just one example of a national leadership program which I was selected to. 1 in 10 orthopedists are chosen to this each year, and I was chosen this past year to serve, and I'm going to be traveling around the country doing some of these leadership programs. So again, it's all because of the program we've developed here. This is the overview of what we're going to talk about today. It's a number of topics. I'm going to try to cover as much as we can. So we're going to talk about knee arthritis, just what is it, the basics of anatomy. We'll talk about non-operative treatments, so not everyone needs surgery, but we'll talk about what things can be done prior to going to surgery. We'll talk about knee replacement, what traditional knee surgery is, what less invasive knee surgery is, and then I'll talk to you about partial knee replacement. We'll talk a little bit about our Institute for Joint Restoration, something unique to our program here, our facility and our program and team. And then I'm going to tell you a little bit more about more recent advances in rapid recovery knee surgery, some things that have changed and developed and working on these past year and a half, and even outpatient joint replacement, what that means. So that's an overview, but we'll start first with knee arthritis basics. Let's just talk about the anatomy of the knee and basic function. So the knee is comprised of 3 major bones. Your thigh bone on top, also called the femur, your shin bone on bottom, called the tibia, and your kneecap, that small bone in front. So here's the thigh bone on top, shin bone on bottom, and that kneecap in front. Every joint in your body is very similar to the end of a chicken bone. You know the white stuff on the end of a chicken bone? That's what cartilage is. That cartilage provides soft protective layer so that every moving joint in your body can move freely and without pain. And that's depicted by this white here. So that's cartilage on the end of the thigh bone, cartilage on the top of the shin bone, and cartilage behind that kneecap. That way, anywhere there's motion of one bone against another, there's that protective layer in between. And that's why healthy joints don't hurt when we move or walk on them. There are also ligaments on the sides of the knee. There are ligaments in the middle of the knee. This one here is actually your anterior cruciate ligament. So you probably hear about that every day. That's the ligament that athletes are common rupturing, basketball players, football players. They're rupturing their anterior cruciate ligament. Well, that's what it is. It's this right here. It's a major stabilizer of the knee, and it's called the anterior cruciate, or anterior in front cruciate because it crosses, because it has a partner back here, the posterior cruciate ligament. So those two ligaments cross in the middle of the knee, and they both give significant stability to the knee. So there's cartilage on the ends of the bone, but then there are also this type of cartilage, which is a meniscus. These two C-shaped pieces of cartilage are the menisci in the knee. Knee arthroscopy is often to treat a meniscus tear. So that's different than the cartilage on the end of the bone. That's cartilage here, a little cushion that can sometimes tear, and knee arthroscopy is a way to treat that, and we'll talk about that shortly. But that's the basic anatomy of the knee. What's the knee do? Well, this is the side view of the knee. You can see how the white cartilage protects the end of the bone, and when your knee moves, anywhere where there's motion of one knee against the other, there needs to be cartilage. That's what lets that motion happen without pain. It is important to know that the knee does feel 3 to 5 times body weight, so someone who's overweight or someone who has knee or hip symptoms losing weight can relieve some of the extra forces on that painful joint. So let's talk about arthritis. What is arthritis? Well, arthritis, when we use the term, simply means the loss of that protective layer. So it means the underlying bone is exposed. So you can see in this picture on the right, as the cartilage gets worn down, now the bone underneath is exposed. That's where the nerve endings are. That's where pain occurs as that protective layer wears down. Or on this lower level, you can see that smooth, healthy cartilage. This is now pitted and eroded. You can imagine walking on that or moving on that knee could cause stiffness and pain and swelling and limitation. So that's what arthritis is. It's typically simply wear and tear of that cartilage. It can be due to other things like trauma, prior surgery, prior injuries, rheumatoid arthritis, or other inflammatory processes can break down cartilage, but most common is simply wear and tear, which we term osteoarthritis, or just wear and tear arthritis as is commonly known. Why does arthritis happen? Well, you can make the analogy, it's like, why do some car tires wear? Well, it may be due to bad quality rubber. Maybe that cartilage was never quite right and so was set up to wear a little bit sooner. Or maybe it was due to the driving habits. That person's tire is going to wear out sooner. Someone who's more active, runs more jumping activities, impact activities on that joint may wear down faster. Or like a freeway, the right heavier lane, more frequently used, that's going to break down sooner than the less frequently used left side of the road. But the bottom line is that arthritis is loss of cartilage. It's when that protective layer is broken down. And we're talking about the knee, but it can certainly occur in any joint. It is important to know that not all knee pain is due to the knee. About a third of patients can actually feel some referred symptoms of an arthritic hip down in their knee. So I've seen patients who felt the pain in their knee, they thought it was their knee, but actually was all referred pain from an arthritic hip above. So I just bring this up for you to know that not all knee pain is actually due to the knee. It could be due from a hip or back or something else referring pain in that area. This is what arthritis looks like on an arthroscopy photo. So we talked about people who've had arthroscopy for meniscus tears. This is using 2 pencil-sized instruments to put a high-definition camera inside the knee so you can have a very good view, and then a second pencil-sized instrument where you can do some procedures like clean cartilage or debride any loose cartilage. So this is what the end of that thigh bone looks like when it's healthy. See how it's white and clean and smooth? That's healthy cartilage on the end of the thigh bone. This is flatter. This is the top of the shin bone below. Again, healthy cartilage, nice and thick. This is a C-shaped piece of cartilage in between. That's the meniscus. So that's an arthroscopic photo, a camera photo of a very healthy knee. These pictures on the right, you can see it's very different. The white cartilage is worn down. There's cartilage flaking off. There are big holes and potholes and divots. That's what arthritis looks like with a camera. It's the loss of that protective layer. This is what arthritis looks like in the operating room. So when we're about to do a knee replacement, you can see on these knees that there are large areas where there's no cartilage left. It's just bald, it's bare. These people have ground down through the cartilage, it's worn down, and now they're walking on bone. That's what gives it the symptoms and causes the pain. This is what it looks like on x-ray. Cartilage is invisible on x-ray. So we know cartilage is there when we see a space between the bones. So this space here, the reason it's there is because there's a layer of cartilage here, and there's a layer of cartilage on top, and the space between is where that healthy cartilage is. We know cartilage is wearing down because here it's very narrow. Those bones are nearly touching. The only way that can happen is if the cartilage in between has worn down. Okay? Now this knee clearly has bone-on-bone arthritis, where it's bone on bone here. But anyone have any idea what's going on here or with this here? What is that? This is actually someone who previously ruptured their anterior cruciate ligament. So that ligament we were talking about before, they had some sort of trauma and tore it. This is what it looks like for someone who's had their ACL reconstructed. So if you look here, you can sort of see that this could be a tunnel, if you imagine. Someone drilled a hole through that bone. Orthopedists will drill a tunnel through the two bones and put a graft, whether it's cadaver graft, patellar tendon, or hamstring graft. That graft lives in the tunnel, and you can see it's in the same orientation as the ACL that we looked at before. So that's what an ACL reconstruction is. It's putting some sort of material, graft, or tissue to recreate the function of the ACL. And then what happens is we fix it to the bone with a staple or a screw. So this is a picture of someone who's had a prior injury. You clearly had an ACL tear, had that ACL reconstructed, and now has bone-on-bone arthritis. So you can tell all that just for looking at this one x-ray. And this is what arthritis looks like when it's quite severe. You can see how crooked this leg is. This person would be quite obvious when they walked into the office. You can see how crooked it is. They're bone on bone, very severe arthritis. The bottom line is there's no cure for arthritis. Once we've lost that cartilage, we don't have a way of growing it back or putting it back onto that joint. It's sort of like that blown tire. Once it's ruptured, once it's blown, we have to replace it or fix it. So there are things to deal with arthritis before that, but there's no definitive cure. So let's talk about non-operative treatments. What do you do if you have knee pain? You're not ready for surgery or it just started. What do you do? The first thing to try are over-the-counter medications. All of us have this in our medicine cabinet: Motrins, Advils, ibuprofens. These are all examples of non-steroidal anti-inflammatory drugs, meaning they provide some anti-inflammatory effect, but they're not steroids. You can take them, they're quite safe. I give them to my children. They help with pain and inflammation. They do thin the blood a little bit, so if you are currently on a blood thinner like Plavix, Coumadin, warfarin, any of those things, you have to be careful taking this because it can thin your blood even a little more. You also have to be careful if you have any kidney disease, because this is metabolized by the kidney and can further aggravate the kidney if you have pre-existing problems. But otherwise, it's quite safe to take. If you have an ankle sprain, arthritis, many of you probably taken it already, it helps with generalized aches and pains because it's an anti-inflammatory. Many of you in the room may be taking aspirin already. You're probably taking it for its heart protective effects. It's another anti-inflammatory, and it does thin the blood a little bit. It has its effect on platelets, just like the NSAIDs we just talked about before. In addition to anti-inflammatories, you can take acetaminophen or Tylenol. This is not an anti-inflammatory, but it does relieve pain, and it's quite safe. Again, I give it to my children and family, and don't worry too much about it. If you're on a blood thinner, because this doesn't thin your blood, you can take it safely. So if you're on Plavix or Arixtra or any other blood thinner, you can take Tylenol safely for those aches and pains, but it's not an anti-inflammatory. Similarly, if you have kidney problems, this is not metabolized by the kidney, so you can take it. You can even take it together. So if you don't have any of those problems I mentioned, you can take Advil and Tylenol in the same day. But you can take one or the other depending on what works best for you. So the anti-inflammatories you take, you always want to take the least effective dose. So you don't want to take it around the clock if you don't need it, because that's when you will start to have the side effects from it. The ibuprofens or Advils, they're meant to be taken on a more frequent basis. So you can start with just one morning and night, maybe take it with breakfast and dinner, so you take it with food. You can take it with lunch as well, so 3 times a day, and then you can gradually increase. You want to take it as little as you need and as short time period as you need. To get the anti-inflammatory effect, you do have to take it regularly, so you might need to take it for 2, 3, maybe even 4 weeks regularly, and then hopefully by then you're feeling better. It's when people are taking it for months to months, years to years, that it can start to have some effects. And that's why you've heard about heart issues or kidney issues with it. But the shortest duration, minimal amount that you need, but Aleve, for example, is a different formulation, so it's morning and night. It's longer lasting. So you just find what works for you. Some people respond better to one than the other, but there's no science to say one is definitively better. Analgesics are another medication you can take. There are Tylenol with codeines, tramadols, and other medications, but we try to avoid taking those long term because if you have a painful joint that requires that, you probably don't want to depend on analgesics. That means you probably need to have something done to have it treated. Now, how many of you in the room are taking glucosamine, chondroitin sulfate? It's a building block of cartilage. It's a natural compound. Because it's a food, it's not regulated by the FDA, meaning that what's in one bottle may not be exactly what's in the other bottle next to it. There's no data needed to have it put on the shelf, and there's no data showing that it actually does anything. It is a natural compound, and it is a natural building block of cartilage, but one of my mentors back at Harvard gave me an analogy that I'll never forget. He said, someone who takes this, it's very similar to a bald man that eats hair. Right? Just because you eat it doesn't mean your body is going to grow it and put it where you want it. Now that being said, there's probably a little downside of glucosamine chondroitin sulfate, but just so you know, there's no data to clearly show it actually does anything. If it makes you feel better, I have no problem with it. At worst, it's an out-of-pocket expense. But the only way for you to really know if it's doing anything is probably to stop it and see if you feel any worse. But it's very commonly taken, as are many of these other supplements, joint juices, ArthroCare Plus, all these things. It's a multi-billion-dollar industry. There are a lot of people willing to pay $20, $30 for these supplements, but there's not a lot of data or really any to say that it does anything, like grow cartilage or anything else. But you can try it. If it works for you, there's probably little harm to it. Physical therapy can help with knee pain or knee arthritis. You can get the leg stronger. You can work on flexibility. All those things can help, but do realize that those benefits can go away within 6 months of stopping that exercise routine. So it's something, if you find benefit from, you need to continue on your own. If all those things fail, the next thing we can try are injections. The most common injection is probably this one, cortisone. Cortisone is a steroid, obviously, and it's a potent anti-inflammatory. Often we'll mix it with a lidocaine or a novocaine, a numbing medicine, inject that into the knee or whatever that painful joint is. It does not regrow cartilage. It doesn't cure arthritis, but it does help with symptoms. The numbing medicine relieves pain. The steroid reduces inflammation, so people can temporarily feel better. Some people feel better for a few days, some people for a few weeks, some people feel better for a couple months. So it's highly variable, but it's something that can be tried. The only downsides to it are that some people will rarely have a reaction or an allergy to it, very infrequent. Some people will get swelling or irritation from it, but it's something that's safe and can be tried. Cortisone, however, you don't want to repeat too often because cortisone can start to have a detrimental effect on the healthy tissues if you do it indefinitely. So viscose supplementation is another option. The hyaluronic acid, the rooster comb injection, some of you probably have heard of, it's a viscous material like this. It's quite thick. It's like a lubricant. It can be injected into the knee. It provides some pain relief and some anti-inflammatory effect, but similarly realize this does not cure arthritis. It does not regrow cartilage. It may make you feel better. Just so you know, our large orthopedic academy has looked at the data and they actually don't recommend it because, not because it does harm, but because there's no great study showing it does anything. Similar to cortisone, some people say it helps, some people say it helps temporarily, and some people say it does nothing. So it's very hit or miss. It certainly can be tried for someone who's going on a trip or wants to try something before surgery, but just so you know, it doesn't work necessarily terribly well. There are a lot of gadgets out there, a lot of devices, and you hear these things advertised. Similar to the supplements, all these devices are a multi-million-dollar industry. People are willing to try anything. These things have not been proven to do anything. They haven't been proven to reverse the arthritis or the pain, but probably with the heat or massage or other things, it's probably helping some symptoms. But do be wary before you spend hundreds of dollars on these devices because these cost much more than the supplements, and I just worry about people throwing money away if they don't need to. But you can try it if you want to. Probably won't do any harm. But like I said before, no data to say it necessarily does anything to help. Let me move on to this next topic about knee replacement. What is knee replacement? Well, knee replacement is resurfacing the ends of the bone. It's a little bit of a misnomer. It's not cutting the whole knee out. It's covering those areas where the cartilage is worn down. So like I said, nearly 1 million are done in the US every year. It's very common. When the knee is worn with cartilage loss, a cap goes on the end of the thigh bone. You can see how this is shaped just like the end of that thigh bone was. And this is flat as a platform. It goes on top of the bottom bone. So that now there's no bone rubbing on bone. It's metal on plastic. That bone on bone surface is removed. But this resurfaces the ends of the bone. So this piece goes on the end of the thigh bone. It's curved and shaped just like all of our thigh bones are already. The idea of these metal implants is to return the shape of what the knee looked like when it had cartilage. So that's why it's shaped the same way. And then this is the platform below, as you can see in that picture. And this rests here so that the knee, when it bends, will roll on it here. But because it's metal on plastic, there's no more pain there. Okay? The top part's cobalt chrome. It's heavy and durable because we don't want it to scratch, because if it scratches, it's going to wear this plastic, so it has to be very durable. This is titanium, in contrast, very light because it's not rubbing against any plastic. So I'm going to pass this around so you guys can feel it. So this is what a knee replacement looks like in the operating room. You can see the ends of the bone are now shiny, right? That's metal, and metal below. Here's metal, plastic, metal, and this is what it looks like on x-ray. Here's that bone-on-bone arthritic knee. Here's from the front view, metal, plastic in between's invisible, sort of like cartilages. You don't see it on x-ray. And then the metal plate below. And then from the side, you can see it's just curved, a cap that goes on the end of the thigh bone, which rolls on plastic on metal below. That's what knee replacement is. Total knee replacement, typically, we usually say there's about a 3-month recovery. You can walk, bike, swim, golf, play doubles tennis with it afterwards. We expect them to last quite well, decades. So we expect lower than a 1% failure per year, meaning we expect 80 to 90% to still be working at 20 years. So we expect them to last decades. And you can see here, this is a graph of how primary hip and primary knees are coming. Over 700,000 in 2010, but you can see it's going to exponentially increase just because there are more people, baby boomers, living longer, staying active. This is traditional knee replacement. Nothing wrong with traditional knee replacement. It works very well. It's a large exposure. You can see the entire knee, and it makes the surgery very easy because you can put everything in. But you can imagine it can take a long time to recover from that because it's a large dissection. And this particular person had staples in their traditional knee replacement. Also, people would use things like these knee moving machines, pretty archaic, really haven't been shown to make any improvement with total knee replacement. It's more historical, but some traditional surgeons will still use that. It's usually a 3 to 4 night stay in the hospital. Up to 80% in some institutions are going to rehabs afterwards, and usually people are on a walker cane for multiple weeks. That's traditional joint replacement. So what's less invasive knee surgery? So what we're doing here is we're focusing on trying to give that same long-term result. We want it to last for decades, but we're trying to do it in a less invasive manner so that people can heal faster, so people can recover sooner. The idea is less soft tissue trauma, less blood loss, less pain, faster recovery. People can get back to their activities sooner. So on the left side is traditional knee replacement. You can see the larger exposure, larger incision, nothing wrong with that, can give you a good long-term result, but we're trying to do it through a smaller surgery on the right so that people can get back, walk sooner, get back to their activities sooner. That's what we specialize in here. This is an example of a knee replacement surgery, and so if you guys don't want to watch, certainly you can cover your eyes for a couple minutes, but there's going to be no blood. There's a tourniquet, so you won't see any blood. This is me dissecting down into the knee. So just going through the skin, dissecting down to the knee joint. About 15% of my patients are actually wide awake watching their own surgery. They're numb with anesthesia waist down. So now I'm in the knee joint. You can see that area is bald. There's no cartilage there. And this is the kneecap. So that kneecap glides on the end of that bone. There's no cartilage on it, so I have to resurface it. The way I resurface it is I take a saw and trim the back. I trim the back to make a flat surface so I can glue a plastic button on the back of it, so now it's going to be artificial. The kneecap's still their own. I just am going to glue on a surface so that it doesn't wear bone to bone. Now's the drill. The drill comes out. So orthopedists really are just carpenters of bone. All right, drills, hammers, and saws. And so this goes in, and what this does is this measures the alignment. This lets me put the implants in the appropriate position so everything's aligned specific to this knee. This surgery takes me about an hour. And like I said, about 15% of patients are going to watch their own surgery. They'll talk to me while I'm doing this operation. So here's the saw blade, and what this doing is it's removing a few millimeters of bone, because you can see there's no cartilage on the end of it anyway. I'm making just enough space to put in that metal implant that you're passing around. So I have to take out a little bit to put in that knee replacement so that overall the knee is the same. So all these guides let me trim the bone precisely so it fits the inside of the implant you're passing around, so it'll fit just right. Okay?
Can the body reject it stuff?
Sorry?
Can the body reject it? Or?
Can the body reject it? Typically not. So allergy to a metal implant is exceptionally rare, case report basis, because these metals are so inert that most people tolerate extremely well. So that's a very, very rare thing if real. Here you can see I've exposed the end of that bone. That bone is now prepared for that implant you're passing around. Now this is the top of the lower bone. I cut a flat platform. That's the area where there's no cartilage remaining right there. So that person's been bone on bone. I have all these trials where I can individually size. So to answer your question, I have trials, I can measure, I can figure out what's the appropriate size for the top, what's the appropriate size for the bottom, and mix and match.
Will one leg be higher than the other?
No, the leg will be the same length. You can't lengthen someone through a knee simply because the ligaments and soft tissues around won't allow it. So it stays well balanced. These are trial implants, so I'm almost done with the knee. I'm going to put these in to see how the knee moves, make sure it's balanced appropriately, has good motion, and it's stable. Once I'm happy with that, I'm going to glue in the real components.
How about the weight?
The weight, you're going to feel the weight. They're going to pass that around to you, and you'll feel it in a second. Even though there is some weight to that, in general, the amount of weight gained after knee replacement is just a matter of ounces. Because after you balance out what's removed with what's put in, it's really minimal net gain. This green or soft putty is the cement. So the cement goes in soft, and then over a matter of a few minutes, it hardens. So I have some time to work with it. I can put these implants in. You can see it's a small incision where we can just get these implants in. And then over a few minutes, this will be rock hard. And so when the person leaves the operating room, it will be solid. It's not a sticky glue. It's more like a grout. It fills the crevices of the bone and secures these implants. And this, again, can last for multiple years, if not decades. And so then I cement in the other side as well. It takes about an hour.
How many hours surgery total?
It's 1 hour. 1 hour surgery.
Total.
Total, whole thing. So I did eight hip and knee surgeries yesterday. So you can get a lot of them done quickly because we do a lot here. We're specialized in doing it here. But about an hour.
Is the knee typically the same size before and after?
Yes, the idea is that we want the knee to, yes, we're trying to recreate what that native knee used to be like. That's right. We don't want to make it bigger or smaller if we can at all avoid it. So that's knee replacement. You've all seen it now. Now you can do it. So let me show you what happens to the patient. So this is actually an interesting patient of mine. This was a number of years ago. And so he took some pictures prior to surgery without me knowing and then gave them to me afterwards. And I've used them because they're actually very helpful. So he had knee replacement because he had bad arthritis. It was bone on bone, and you can see how the knee on the right curves. See how it curves outwards? It's bowed like a banana? That's because of his arthritis. He was bone on bone. And you can see here from the side, see how he can't straighten his leg? It's permanently stuck bent because of the arthritis. So he took those pictures without me knowing and gave them to me now, and it's great because after doing his knee replacement, you can see it there. Here's that same picture a week after surgery. The knee's straight, right? It's aligned correctly, so I can straighten that. The knee also goes all the way flat. So by taking care of that arthritis, we can improve his motion and improve his alignment. This is a number of years ago, but this is him walking out of surgery roughly about 2 days after surgery on a cane. Again, he's a physical therapist, but we get people up moving right away after surgery, try to improve the recovery and speed their ability to get back to normal activities. It's rock solid, that's right, so you can walk right away. So both our hip and knee replacement patients, we have them walking right away now. This is him walking in clinic at his 2-week appointment. It's hard to tell which knee he had operated on. So this is a number of years ago, but this is him 2 weeks after major knee replacement. So this is an example of someone who has very bad arthritis. Patient of mine, look how crooked that leg is. He came in walking with that, and his knee is not only bone on bone, but shifting off of the other. But with knee replacement, you can correct that. You can make the leg straight again. You can put it back to how it should be, so you can see a dramatic difference. And even for a knee replacement that fails, this is a knee replacement that failed. It was about 15, 20 years old by another surgeon. They referred it to me for revision because it had collapsed. She had significant bone loss. But with added augments, stems, and revision procedure, we can rebuild that and put it back so she can walk on it with full weight bearing. So all these things are possible, both in the first-time knee surgery setting as well as the revision surgery setting. So knee replacement, arthritis is gone because all that cartilage is now removed. So there's no cartilage to wear down. So arthritis is gone when you have knee replacement. That's the one cure for it, really, is to replace it. So you've gone through the non-operative management, you've gone through the medications. When do you do it? Joint replacement, whether it's hip or knee, it's elective. I mean, you don't ever have to do it. It's not cancer. It's not a diagnosis where you're going to die or anything like that, but it's about quality of life. And so if the arthritis is leading someone to need narcotics or pain pills, or they can't walk, they can't exercise, they're gaining weight, clearly they want to intervene because the longer they go like that, the harder it will be to recover from an eventual joint replacement. So it's about quality of life. It's about when you can't do the activities you want to do when your health is suffering because you're modifying too much. A little activity modification is okay, but if it's starting to impair your health or make you gain weight, you probably want to have something done. But that's a personal choice for each individual. Let me talk about partial knee replacement. So you're all now experts in total knee replacement, and that's very common, and everyone knows about that. But what about when someone has arthritis in just one part of their knee? Do they have to have the whole knee replaced? So we were talking about knees like this, where the arthritis is spread out through the knee. But what if someone comes in and they're either younger, or let's say they just have isolated arthritis on one part? Maybe they don't want to have that implant passed all around. Well, that's where partial knee replacement comes in. Partial knee replacement is the same idea. It's metal that rolls on plastic on metal, but it only addresses that one part of the knee that's worn. So you can see on this x-ray, it's very different than what we've looked at before. It's only on one side of the knee. From the side, it's the same idea, metal, plastic, metal, but the rest of the knee is preserved. Why do this? Well, the benefits are it's less invasive, it's bone conserving, it saves every ligament in the knee, less blood loss, better range of motion, faster recovery. So there are benefits in the properly selected patient. So this is partial knee replacement. You can see it's metal on metal, but you can see it's only on the inner part of the knee. You can see how much smaller and less invasive this is than the total knee replacement. In the properly selected patient, they have data going out 15, 20 years where these 90% haven't been revised. So they can last a long, long time. The key is going to a surgeon who can tell you if you're the right patient for it. Because if you have it done and you have arthritis coming somewhere else, it's going to fail and you're going to need a total knee replacement at some point. So partial knee replacement I've done in people in their 40s because they're young and we don't want to do total knee replacement yet. I just saw a patient of mine who's 88 and I did a partial knee 2 weeks ago. And 6 weeks before that, I did his other partial knee. But the reason is that partial knee replacements can have some benefits over total knee replacement. Total knee replacement works great. That's why so many people are having it done. But partial knee could potentially be even better in some cases. These studies show that function can be superior, range of motion can be better. Patients often prefer it if they have a partial on one side versus a total, and overall better results. Now, why don't you hear about partial knee replacement more? It's a more difficult procedure to do, and there aren't many specialists doing it. And so partial knee replacement is probably only applicable in maybe 1 out of every 10 patients. And most surgeons out there only do about 10 knee replacements a year, meaning they only see one partial knee replacement candidate a year. So they probably won't do a partial knee replacement, they'll probably do the total knee replacement because that's what they know how to do. But if you see someone who's a specialist who is well versed in partial knee replacement, they can best tell you, are you a candidate or not? In this picture on the right, you can see here's total knee replacement, here's partial knee replacement. You can see the difference. Because these implants go all the way across, what ligaments are removed? The ACL and PCL. But see, with a partial knee replacement, that area is spared and those ligaments are also spared. So that's the benefit of partial knee replacement. I do all the partial knee replacements in our group as well as total knee replacements, and I probably do more partial knee replacements than anyone in Northern California is what my reps tell me. But I like doing it, I have a passion for it because in the right person, it really can provide phenomenal results. The most common partial knee replacement is the inside of the knee, but isolated arthritis can also occur under the kneecap. And for that, there is also a partial knee replacement option. So instead of replacing the entire knee, maybe just replace the kneecap. And you can see the kneecap's that small bone in front, and that kneecap glides on the femur when that knee bends. You can put a plastic button on the back of the kneecap, just the same as a total knee replacement. You can put a metal groove for that kneecap to glide on the end of the femur, but you can see it ends there. All the rest of the knee stays that patient's own, and all the ligaments stay their own. So in the right patient, this spares them a lot of extra surgery. So let me show you an example of an animation of what partial knee replacement is. Here's a knee from the side view, and you can see where the arthritis is. It's just on one part of the knee, and so it's worn down. Instead of doing a full knee replacement, in this animation, you're going to see just the inside of the knee replaced with metal, plastic, and metal, just like the model that you're passing around, sparing the rest of the knee. This is a video, again, a number of years ago of a young lady. 2 years prior to surgery, she had knee pain, but still had space, still cartilage there. And 1 year prior to surgery, pain, but still cartilage. Right before surgery, you can see that the cartilage is worn down and now it's bone on bone. So we need to do something. She's in her 40s. We opted for partial knee replacement because her arthritis and symptoms were only on the inner aspect of her knee. Replace that inner part of her knee. That's from the front, that's from the side view. And then you're soon going to see, this is her less than 2 weeks after surgery, after her knee replacement. So she has wonderful knee motion, and she can already walk quite well, as you'll see here, less than 2 weeks after surgery. So that's partial knee replacement, and that's a number of years ago. So let me talk to you a little bit about our program, our joint replacement program. Our Institute for Joint Replacement is somewhat unique in that we have a preoperative education class. So prior to surgery, all of our patients will attend a class taught by our therapists and nurses so that they and their caretaker know everything they need to know about before, during, and after surgery. This is supplemented with a binder full of information, that same information from the class that they can refer to throughout the process so they know what to expect in the healing phase. Our personnel, we're fellowship trained. We have anesthesiologists dedicated to the surgery, OR techs, nurses, therapists. This is all we do. It's a huge group of people. We do a large volume, like I said here, so we're very fortunate to have such a dedicated team. One of our offices is in Menlo Park. The other is on the top floor of the Institute for Joint Replacement building, and that's our office there on the top floor. The middle floor is where we have our patient rooms. So it's a unique building in that it's separated from the hospital. So there's no one unhealthy in the hospital. Our healthy patients are isolated from the sick ones in this 3-floor building. There are 30 private rooms. As you can see here, the nurses and therapists, all they do is treat our joint replacement patients. So unlike other institutions, you don't have to worry about a roommate or someone else on the floor having a different illness or infection, or nurses going from infected rooms to others. All our healthy patients, all our joint replacements are in this building. So with our volume of surgery, this allows the opportunity to present data, go to meetings, and share our results with other surgeons across the country. These are just examples of research studies that I presented. So we have different sizes for different people, or hip replacement surgery, or even a gender type replacement that's available. But again, these are just all studies we're frequently doing, presenting at national meetings. Here's Fremont. You all know it here, a small community hospital for the Tri-City area. But our joint replacement patients actually come from a wide range of places. So we have people coming from all over Central Valley Peninsula, out of state. They all come here, and we're very honored that they'll do so because we provide a service that they may not be able to have near their home. So why? Well, it's because our program has been recognized. PRC is a satisfaction survey, and quite frequently our patients rate us as one of the top facilities in the country, even #1 for a number of years. And Becker's does hospital reviews. You can look it up. It shows our various accolades as well. And Health Grades is online. It rates hospitals across the country, and 5 stars are their highest rating. We're the only institution in the area that gets the highest rating for both hip and knee replacement, and we've had that since 2002. We were the #1 joint replacement center in all of California just a couple years ago. And Consumer Report about 2 years ago came out with this hospital evaluation across the country looking at safety. So who has the safest hip surgery, who has the safest knee surgery? In California, you can see Washington Hospital got their highest rating. Stanford and UCSF were there in the middle average. And in terms of all hospitals in California, we were one of maybe 8. And then for hip surgery, you can see we were one of maybe 5. So in the state of California, we were probably only one of 2 or 3 that got the Consumer Report's highest rating for both hip and knee surgery. So now I'm going to talk to you a little bit about what things have advanced even more so than what we just talked about, more rapid recovery. So over this past year and a half, I've been working on some pain management protocols. Someone asked about pain management protocols and rehab protocols to speed the recovery even more. So the elements of surgery are more involved than just one thinks about. You know, surgeons are used to thinking just about the act of surgery, but there are all these other things involved: patient selection, patient education, perioperative protocols dealing with pain, nausea, bleeding, wounds, the surgical technique, of course, but also rehab protocols, the support system, and follow-up. All these things are critical in order for someone to have a good result. And surgeons only used to focus on this. Now we're trying to focus on the whole package, because if we do everything well, we can have a rapid recovery. We need to have everything successful for someone to have outpatient joint replacement. My feeling is if any one aspect is not very good, we probably won't succeed. So for my patients, I'm always trying to improve all of these things. The main things we're going to talk about, the major advancements, pain control. So pain control is typically treated with just narcotics, morphines or Vicodins, Percocets, but those all have side effects. And so when we traditionally would use that, while it would help people's pain, it would delay their recovery in other ways. So narcotics, all these things we're used to hearing about, morphines, Oxycontins, Vicodins, while they help with pain, there are downsides. And this interesting study showed that as recently as 2012, in this study of 1.6 million patients, patients who received intravenous or IV pain medicine in the hospital, 3 out of 4 were getting narcotics only. In spite of all the other pain medicines available, that's all they were getting. So it's a trend and it's a routine that physicians and surgeons need to change, and I educate other surgeons about that now. The reason is this, because pain is actually a very complex pathway. You can intercept pain at various ways. Opioids work up here, but you can intercept it anywhere along here. We can use local anesthetics like the Novocaine or injections. We can use anti-inflammatories that we talked about before. We can use peripheral nerve blocks. Our anesthesiologists can do epidurals or regional anesthesia. We can use alpha agonists. We can use some more NSAIDs. We can use Tylenol. We can use all these things in addition to some opioid, but you can see we don't want to neglect all these other pain medications available to us. So I'm working a lot in this past couple of years on how to create a good pathway of multimodal analgesia. And so I actually give lectures at meetings and I give webinars on trying to maximize the benefit of using many different pain medications at low doses to avoid any side effect of any one in particular, especially the narcotic. So I will use something as simple as Tylenol. Tylenol, while you have in your kitchen cabinet and wouldn't think that it would help with major pain after surgery, it does. And there's also intravenous Tylenol, which is now available. Using that around surgery has been shown to reduce narcotic use and improve pain. Or things like Celebrex or other anti-inflammatories, there's intravenous forms of that, so you can use that around surgery. This is just an example. It's a very busy slide, but it's an example of how a different route of administration can make a big difference. What the green shows is when you use Tylenol suppository, the yellow is a pill form of Tylenol, and the red is intravenous. So what it shows is that the levels get much higher, much faster when you use that intravenous Tylenol. And here, the level is much higher and more sustained. So just by changing the route of administration, something as simple as Tylenol can have a more dramatic effect on pain relief. And this is what regional anesthesia is. We can have our anesthesiologists do nerve blocks. They can do epidurals or regional anesthetics to avoid general anesthesia. But some of these medications can help provide more sustained pain relief. I've also been working with a company lately who's been providing this unique medication, which is like Novocaine. It's like what you get at the dentist, but instead of wearing off in a couple hours, this medication is formulated in such a way that it wears off slowly over potentially 2-3 days. So you can imagine I can inject that around the surgical site of a hip or knee and hopefully provide pain relief even better. Because I use these medications and we have a large volume, I'm actually involved in some multi-center randomized national controlled studies about the effectiveness of these medications. Another advancement is not specifically a pain medication, but it's actually something used in the cardiac realm. It's a clot stabilizer, so it helps minimize blood loss after surgery. So by using this medication, people have less bleeding, lower transfusion risk, less pain, less swelling. This has dramatically improved how people recover after joint replacement. Similarly, there are devices which can help stop bleeding by coagulating and sealing soft tissues. And I even take it to something as simple as a suture. You wouldn't think a suture could make a big difference, but rather than tying knots and closing the wounds, there's a barbed suture available which allows me to close the incisions watertight so that people can start walking and moving right away and the tissue be fully sealed. So these small advancements, rather than using staples, which are not comfortable, they leave ugly scars and they leave poke holes in the skin when you remove them 2 weeks later, all of this melts away under the skin. So after a knee replacement, you can see at 2 weeks, it's a very dry wound, clean. 6 weeks, you can hardly see it. In 12 weeks, it's almost completely gone. So these types of developments, having less bleeding, better wound closure, can speed the recovery overall. And lastly, I use something like this, which is a dressing, which is becoming much more common. It's a waterproof dressing, which has a little bit of an antimicrobial layer, and it goes on the incision and stays there for a week. It used to be we would put dressings on and you have to change it every day. It would be maybe not clean, depending on who's changing it for you, and the tape would be irritating to the skin coming on and off. This stays on for a week. And recent studies have shown this may even help reduce infection after joint replacement. So in my mind, by focusing on all aspects of care from beginning to end, you can continue to make improvements and continue to speed recovery for these conveniences of our patients. And this leads to something like outpatient surgery. So outpatient joint replacement is becoming more and more common. And so we can do now joint replacement on an outpatient basis. This was a talk I just gave at our recent hip and knee national meeting in Dallas about same-day surgery, how to get to doing outpatient joint replacement. So lecture to fellow surgeons about how to do that. And the bottom right was an abstract of my experience by discharging total knee replacement patients 1 day after surgery. So how do we do that? This is partial knee replacement surgery. The woman on the left had the kneecap only replacement, and the gentleman on the right had the inside of the knee replacement. And so with these better pain protocols, with these faster rehab protocols, I was able to get them up walking. This is them walking 3 to 4 hours after surgery. And so now what you see is instead of staying overnight, instead of staying multiple days in the hospital, they're going to walk without a cane, without a walker, without an assist device, and be able to go home that same day. So people can come in, have a partial knee replacement, and go home that day. People do better in their own home. Studies show people don't do as well when they recover in a rehab. So people typically are better sleeping in their own bed, eating their own food, rehabbing at home. And that's the idea of this type of procedure. This is just a video I get in my email every once in a while. This gentleman had double partial knee replacements by me. He loves to ski, so he sends me these videos every once in a while, which is fun to see. He's a lot better than I am, I can tell you that. And then here's total knee replacement. You just watched that surgery. And there were some oohs or ahs during that surgery because yes, it is a somewhat gruesome surgery. When I watch this, I think, wow, this is pretty involved. But starting a year and a half ago, I made the dramatic change of saying, I want all my patients walking day of surgery. So even after this surgery, I have all my patients, whether they're 40 or 90, walk that afternoon. Not the same day, but with walking the day of surgery and with better pain protocols. These are examples of two patients early on in my experience, about a year ago. You can see the one woman on the left is going to walk with a cane, and the woman on the right is going to walk under 24 hours after surgery with no cane at all. So both of these ladies had total knee replacement, and they're going to go home less than 24 hours after surgery. So that's the change. That's the change that has been going on. This is a gentleman, you can read about his experiences with partial knee replacement, and this article was one of my first patients who went home day after total knee replacement, which is much faster than really anyone else out there. And this has led to outpatient joint replacement. So our hospital here is great, and we have a wonderful facility here. But because I'm able to do partial knee replacement, get people out even sooner, just in the past couple months, I opened up our outpatient joint replacement program where I'll do some of these procedures in our surgery center across the street. So there's no reason for these people even to come to the hospital, because if they're only in the surgery center for a few hours, I can do it there and they can go straight home from there. So people are going home right after surgery. But with that, again, I appreciate all of your attention during this session, and I'm more than happy to answer all those questions. Thank you very much for your time.